That's going to be Karina Raykhelson, professor of the Department of Gastroenterology and Dietology of St. Petersburg, Northwest State University. Cholestatic liver disorders, the amount of diagnostic search. Good day, esteemed colleagues. That's the second day of our conference. We talk about multidisciplinary team. Yesterday we talked about the pancreas, but today we'll talk about the biliary tract. So we know that it's one single system, and it's hard to divide it. And talking about the interdisciplinary approach, we understand that we should work together on one hand. On the other hand, we understand that we are at different poles. And looking at this animal from the fairy tale, we understand that surgeons and therapists are at different poles and different extremes. But those 2 days, they imply that we should work together. So, looking about cholestasis, we understand the cholestasis is divided into intra and extrahepatic, and we know that what indicates intrahepatic cholestasis is mostly related to therapists. The extrahepatic cholestasis is mostly the matter for surgeons, for sure. But are you sure that it's for sure? Look here. As to our understanding, we surgeons and physicians, we have different clinical. We think about different clinical signs. Cholestasis, from the physician point of view, it's an itching, and mostly they will look at the alkaline phosphatase and gamma glutamyl transpeptidase. For surgeon, the signs of cholestasis is jaundice, and first of all, they will look at the bilirubin levels. But if you look at the main reasons of cholestasis, both intra and extrahepatic, our positions and points of view are quite mixed. These are the main reasons of extrahepatic, similarly surgical cholestasis. But there are lots of disorders related to therapists, to physicians, which are treated by therapists or internists mostly. Talking about the intrahepatic cholestasis, which is mostly of the therapeutic pathology, nevertheless, there are lots of items with hepatocellular and cholangiocellular cholestasis, where at this or that stage we should talk to surgeons, and in some conditions surgical treatment looks to be more important. But let's talk about what cholestasis is. And in 2008, EASL published its guidelines, which is the main association for us, and we're members of the association, many of us. So look at the definition of cholestasis. Diagnostic criteria as to EASL guidelines. There are two, so to say, provisions. It's alkaline phosphatase higher than 1.5 times upper the limit of normal, and gamma GT levels up than 3 limits of normal. So what should you do when we see those parameters? These are EASL guidelines of 2009. So surely, to diagnose cholestasis, the basis of our diagnosis is detailed history and physical examination. We could believe to equipment, but history and examination are very important. Then yesterday we talked a lot about algorithm, and we should follow the algorithm. So first place is ultrasonography. It's a screening chip method which makes possible to differentiate which cholestasis we're dealing with, extra or intrahepatic. The next item, that's another typical cholestatic disease. It is a typical biliary cirrhosis. That's why for adult patients we'll look at the antimitochondrial antibodies. Then cholangiopancreatography, MRCP. That's the next step, which should be considered in all patients or for all patients where cholestasis is of unexplained origin. Endoscopic ultrasound. We're talking about them those 2 days. It's an alternative to MRCP. when we talk about the distal obstruction. Then talking about the ERCP, again, we discussed this yesterday and going to do it today, that we're trying to come to the minimal invasive methods, and according to EASL guidelines, ERCP is considered considered as a reserve method where we can't get the data through other techniques. Another routine procedure for therapists, invasive procedure for therapists, so to say, liver biopsy. For cholestatic disorders, it has only the 7th place, not the first one. And the last item, this is what we are not doing. That's a genetic testing for canicular disorders, which makes possible diagnosis of congenital cholestasis. And that's an algorithm by EASL guidelines. Once we diagnose cholestasis and confirmed, and we see, as we see first step, it's ultrasound. If ultrasound doesn't show us the reason of the disease, if it's not cholelithiasis as a reason, then we'll look at the autoantibodies, which make possible to think about autoimmune cholestasis, then the drug history, because there could be drugs involved in liver disease. And the 4th step, it could be EUS or magnetic resonance cholangiography or ERCP. That's a step when we think about sclerosing cholangitis, or we need some therapeutic interventions. Couple of words about the liver biopsy. So yesterday you heard it, and today you're going to hear about morphological methods. What is a reliable and highly informative method? Histologic evaluation should be done if in biopsy we see at least 10 portal fields. Only that case we can talk about that appropriate histologic evaluation, because at one slide we can see different stages of process, and we even could see nothing if we do not see enough of histologic material. For instance, if we see such a piece, we can hardly get some reliable information. And when we talk about the biopsy defects, mostly we're talking about the defects of procurement or about the insufficient number of material. But my course morphologist, and he asked you to look at this, asked me to draw attention to that issue specifically. Histological defects might appear at all stages: sampling, fixation, delivery, processing, imbibition, so on and so forth. So at this piece of tissue will say nothing to us, and we as doctors will feel upset. But in any case, all biopsy findings could be divided into 3 groups of disorders. First is the disorders involving bile ducts, like PBC, PSC, sarcoidosis, idiopathic ductopenia, or drug-induced cholestasis. They have quite a typical morphology, though it's not always in this small piece of liver we can find clear-cut changes. The next group of disorders, which not involve bile ducts, but they have the typical signs. We're talking about classic cirrhosis up to the accumulation disorders, and also situations morphology could help us, could be of help, or could be in vain. And also there is a third group of disorders. Usually there's a disorders with hepatocellular cholestasis, when actual morphologist cannot say much, because with such disorders like benign recurrent cholestasis, parent anaplastic phenomenon, and some others disorders, there are not that many of changes in the liver, and histologic histologic report will be of low informative quality. Immunohistochemistry of a great help for us. At the left you can see our hematoxylin eosin dye or staining, and with considerable infiltration For morphology, it's hard to assess the blood vessels, and even it's hard to see biliary ducts and histochemistry. And first of all, when we talk about cytokeratin 19, it helps us to see biliary ducts and obtain additional information. A couple of words about the treatment, because I'm therapist here. For us, when we send the material for morphology, it's very important to know if the patient was treatment. Today we have two drugs to treat ODSA and artemether-heptrol. There are drugs of different mechanisms. They could be used together. They're synergistic, and they could be rather effective for some of the disorders. We expect for a breakthrough in treatment of cholestatic disorders, because those successful results reached with using of UDCA, they resulted in appearance of derivatives of the acids, and we see the nor-UDCA drugs to appear and obeticholic acid to appear. So we see some successful developments in this respect. Why I'm saying about that? Because referring the material for morphology, we expect morphologists to confirm our diagnosis, but effective treatment might result in quite considerable changes. With UDCA, morphology will not describe classic cholestasis. We gave hormones, and there will be no infiltration. Another case, we gave some drug which affected the liver and will change the liver morphology and change the diagnosis. And the third situation, quite more typical for infection disorders, when our treatment either results in the immunodeficiency with a different morphology, or we gave, for instance, we might give too much of blood agents, and which might result in superinfection. So we should take into account all the situations when we're looking for morphology diagnosis. But morphologists cannot diagnose. They could say how it looks like, what it appears to be. Talking about the classical disorders, it's advanced patients, because patients they have even typical habitus, not just only clinical picture. We could look at the cholestatic profile and antimitochondrial antibodies. Biopsy is not done usually, but do you know lots of patients with typical clinical, so to say, pattern? We can differentiate patients with PBC and PBC with autoimmune hepatitis signs. And here you see we have to use some specific diagnostic criteria. This disease, some specific criteria, which you could obtain 2 of 3 signs of both PBC and autoimmune hepatitis. And all the criteria should be morphological. If PBC and it's overlapping with AMA, this is a different. It's a BCL2 staining, which helps us to differentiate for differential diagnosis. While PBC is a therapeutic disease, on the other hand, there is a group of disorders which are exactly on the crossroads of the activity of surgeons and therapists. These are different sclerosis cholangitis. They could be divided into 2 groups. It's a secondary sclerosis cholangitis with various reasons to development, and sclerosis cholangitis of unknown origin, which are the most complex diagnostic cases for us. Primary sclerosis cholangitis, PSC, and IgG4-related sclerosis cholangitis, which is considered as a systemic immune-associated disease. And looking at the cholangiograms, we understand that these disorders they're not completely alike. They're different. We see structures are different, but that's a problem. make it's an issue when we feel like it's hard to diagnose, to establish a clear diagnosis. Yesterday you heard the talk about the IgG4 related cholangitis. Today I'm showing the latest Japanese classification, diagnostic criteria of IgG4 related cholangitis of 2012. What's that based upon? On the imaging of biliary tracts, on presence of IgG4 related process like autoimmune pancreatitis or retroperitoneal fibrosis, on the elevated levels of IgG4, and on histology. So basically, one of the most important issues here is a histology examination, which shows a range of typical zoonotic pathognomonic signs. And additional options for diagnosis are steroid or effectiveness of steroid therapy. But specifically, in those diagnostic criteria stresses that when diagnosing PSC through the hormone treatment, we should exclude those diseases where hormones would be ineffective or even harmful, like PSC or cancers. And we should use various endoscopic methods and obtain biopsy material, including those EU's FNA biopsy, which we discussed yesterday a lot. And looking at the classification of cholangiography in IgG4-related cholangitis, the name of my talk, the field for diagnostic search, actually it implies it. What should we differentiate cholestatic disorders with? First step, when the CBC only is involved, we think about the malignancies of pancreas. Second type, it's related to intrahepatic involvement. Here we think mostly about the PSC types 3 and 4. They involve hilar area, and here we think about cholangiocarcinoma. And those methodical capacities we have those days, including various endoscopic and biopsy methods, they will depend on the type of the disease. And that's an algorithm of it when we suspect IgG4 associated disease. First of all, we should exclude exclude pancreatic tumor. IgG4, the borderline is 135. And yesterday we talked about the numbers like 150. So there is the same diseases, but there is no one accord in different specialties. And if we exclude the pancreatic cancer and we see high IgG4, it means that we can give hormones. Second type of this, we think about the PSC. We can discuss if to biopsy the liver. But here, the diagnostic process is mostly based on IgG4 values and association with inflammatory IBDs and with steroids. And it's types 3 and 4. We think about cholangiocarcinoma. We think about the potential malignization. And here we use and steroids therapy is last resort, so to say, for us in diagnostic routine. On PSC, it's a headache for us. It's a quite rare disease because it is well known that even in the world, only Scandinavian countries have adequate statistics on PSC morbidity. Other countries provide evaluation numbers. The matter is that to diagnose this patient takes lots of time. For us, if we see cholestatic biochemical pattern, if we see typical cholangiogram changes, it takes 4 to 5 years to see them. The second situation, if the patient's initial structure was taken by surgeons, he has a cholelithiasis, and then the stricture is considered as a post-op complications. Those patients are lost and they're not diagnosed on time. Look again at the EASL guidelines. PSC. Diagnosis of PSC is made with biochemical using biochemical markers of cholestasis. We also should exclude secondary sclerosis and cholangitis. And talking about the biopsy, today PSC has two groups. It's a simple PSC, which could involve small and large ducts, and it could be more benign PSC involving only small ducts. on the smaller ducts. And regretfully, biopsy material helps us only if small ducts are involved, and it's not that often helpful. That's why liver biopsy is done only if we see insufficient, if we have not enough information from MRCP. Then ERCP, there are two indications. If MRCP is uncertain, if MRCP is normal, but patient has IBD, because PSC and IBD, they're like twins, because they say that PSC is not the Crohn's disease, and it's a third nosology, it's a separate disorder. And the typical sign of PSC, it is so-called, it is a paraductal concentric fibrosis, and as to our data, we can see it only in 13% of cases. That's why biopsy is of poor help for us. A special problem in PSC, that's an issue which we saw yesterday during the surgery, that PSC is related to the sharply increased risk for hepatobiliary malignancies. First of all, we're talking about cholangiocarcinoma. If there is a IBD, we're talking about colon carcinoma and colon tumors. And in Scandinavian countries, as leaders in this field, they talk about the risk, which is 161 times higher in this group of patients of cancer versus the general population. That's a crazy number, actually. And so, if we think that if we think about PSC in a patient, if we suspect this diagnosis, we first of all should not miss a potential malignization. So, if you diagnosed PSC, and if we don't see any IBD signs, we still have to do total colonoscopy in those patients. And if the patient has an IBD, then we should do the colonoscopy every 1-2 years. To exclude gallbladder pathology, we should do abdominal ultrasound. And for all the diagnosis of cholangiocarcinomas, you see that's quite a delicate phrase, so to say. We don't know how often or what should be done not to miss cholangiocarcinoma. You know that's a complex diagnosis. US guidelines, unlike European ones, they clearly recommend that we should look at CA19-9 or at least once every 6 months. Another reason of cholestasis is a gallstone disease called etiologically, and we understand that if it's asymptomatic, it's a physician matter. If there are symptoms, that's an issue for surgeon. And on one hand, yes. On the other hand, esteemed colleagues, let's be honest. Regretfully, in majority of hospitals in our city and even country, if the patient is taken by surgeons, that they will be treated by surgeons. In the hospital where I'm at the moment located, it's hospital 122. We see patients here where surgeons said you don't need a surgery. It's not that often the case in other hospitals. Another topic: should we do the surgery on asymptomatic gallstone disease? World Gastroenterology Association said that asymptomatic gallstone disease does not require surgical treatment because we're talking about the risk to benefit ratio. Though the cholecystectomy has a minimal set of complications, it is still higher if asymptomatic stones are not treated surgical. Those are several exceptions. First of all, if you plan another abdominal surgery so you could remove gallbladder, if patient lives in the place that he could not reach a hospital, if there is a colic, is the regions with high risk for malignization, but we're not related to them, we're not Chile, we're not Bolivia. Patients with immune suppression, patients with insulin-dependent diabetes, patients with rapid weight and loss and gain, patients with, so to say, porcelain gallbladder. So there are not that many of indications. So why I would like to show it for surgeons. We should remember that we should not treat patients if they do not feel any pain. You have lots of work to do with other patients. And two other disorders which I would like to mention as a therapist because they imply diagnostic problems. First of all, it's binary recurrent intrahepatic cholestasis. There are Malignant cholestasis like bile disease, and children die because of it, but mutations could be not often not such bad, but sometimes patients might develop jaundice, and it takes 1 to 2 months for therapists to find the reason. And then it disappears during the diagnostic process. And the first type of brick is accompanied by keratitis. Brick 2 can be accompanied by the gallstone disease, and they think that's the reason. But it's quite a complex diagnosis. It's a diagnosis of exclusion because, as far as I know, we do not have primers to diagnose the disease, and gene sequencing is a very expensive procedure. So we should remember about this possibility. And another disease, congenital disease, which is not cholestatic, so-called Gilbert syndrome. And maybe I should mention it, but on the other hand, 5 to 10% of the population. I often saw cases when we have a patient with some pathology of biliary tract, with some stricture, and with our mind we understand that this stricture is not obstructive, but we see bilirubin of 60, and then we start to think what should do with the patient. Quite often it's just a Gilbert syndrome component. If it's an indirect bilirubin without any signs of liver failure, we should take a simple gene test, and you will see that those 40 units of bilirubin are not that big deal. And I think that's it, what I would like to tell you about. And I hope that during my talk and during today and yesterday, surgeons and therapists, they'll become closer to each other, and we will work more into, say, one accord. Thanks a lot, Corina, for this bright lecture. Esteemed colleagues, are there any questions to our speaker? I have a question. There were several diagnostic algorithms and differential diagnostic algorithms, the liver biopsy and EOS MRCP, which in diagnostic algorithms, what is the first place or the second place? And if you know, Dmitry, this EASL scheme shows there is a arrow back and forth. We can change the trends. If we think about the disease with clear-cut morphology pattern, if we think that it's hepatic cholestasis, and cholestasis is the first place. If we think about the extrahepatic, then the first place would be MRCP, and if it's not informative enough, we talk about the distal part, then EOS should be used here. But if one method doesn't provide information, then we should use another method. So algorithm is actually based on the preliminary diagnosis. And have you seen in your practice that from the first point of view, you see that the patient has an intrahepatic cholestasis, you do biopsy, and respectively, you see that it's an extrahepatic. And in a clinical practice, we don't know what cholestasis is. There are such patients. And if we think of it's an extrahepatic cholestasis, and as said, for us, PSC and IgG4 cholangiopathy is the most complex diagnosis for us. We try to start with a minimal procedure like MRCP, but in some cases biopsy is the first step. But if we don't know where obstruction is, then the first method for us is cholangiography. But could you please comment on that? Because in my clinical practice, I had a case in one of the hospitals, in hepatology clinic. The cholestatic patients, we did biopsy, and we found that it was a mechanical jaundice. In biopsy channel was a source of bile leak, and patient was to undergo surgery because of the peritonitis later on. So how often those complications appear? And what do you think? To prevent the risk of post-biopsy complications, we should, at least at the ultrasound, consider if the bile ducts are dilated or not. Well, the EASL algorithm, it shows it's ultrasound. Ultrasound is the cheapest and the simplest method. Biopsy, no matter if we like it or not, it's not the first choice. We do not do biopsy for acute disorders, for acute cholestasis. We usually do it for chronic disorders if the disease lasts for more than 6 months. And that situation you described, it's a quite rare case. On the other hand, we should understand that the liver it likes to have two diseases. We know that with any liver disease, we could see gallbladder stones, and we know quite often that there are patients, there could be PSC patients who start to develop bilirubin, but then we see the stone, which is the reason for that. And as a surgeon, I should ask you about the lysolytic therapy, taking into account that asymptomatic patients should not undergo surgery. What do you think about lysolytic treatment? Well, on the one hand, lysolytic treatment has a place to use, but on the other hand, we do not see often the stones where it could be used. In our primary diagnosed patients, we're not often seeing so soft stones that could be dissolved. So from the point of lysolytic therapy, in a newly diagnosed gallstone disease, it could be used, though we could use densitometry on the stones to see if it could be used or not. But lysolytic therapy, it has another place to use. We should understand that the first stage of this is a sludge, and so we could prevent stone formation. A second group of patients are post-cholecystomy patients, and here we prefer UDCA because it effectively prevents repeated stone formation. But we should say that every patient is an individual case. Esteemed colleagues, maybe here's the questions. Maybe you have questions here? No? So thanks a lot, Corina.